So this is Senate Appropriations, and this week we're kind of using it as an opportunity to get ourselves up to date on what is happening. And so the first item is to talk about our home and community-based plan. We obviously had utilized some of the potential of that plan as we built our budget for this year, and wanted to have the opportunity about where are we. One of the things that I also, while I'm thinking of it, I'm on a board of a residential care home, and they said they just got notice of their current next year's rate. We budgeted for July 1st startup, didn't we? I realize this isn't on the agenda, but now that I have a chance to ask, and they said they just were told, and that would be at Dale, I assume, what the new rates were starting in February. Does that sound familiar? And why would it have taken from when we passed the budget to February? Because some of those rates, I think we thought they were for the full year, right?
So is this the personal needs allowance piece of it? Because that can only happen in January.
No,
Okay.
it's a reimbursement to the facility.
And it's a residential care facility? February.
Well, anyway, never missed an opportunity to raise a question.
Sure.
And if you could find out, I was just, why would there be such a long delay between, because obviously facilities are really stretched relative to workforce costs and hiring, contract nursing, and it just seemed like, I was kind of surprised, and maybe I didn't understand correctly. So if you'd be happy to.
Yes, we'll be happy to take that back to Dale.
Yeah. All right. Thank you. And Shayla, is Shayla coming or?
Shayla's not coming.
All right. Well, that's great. We're more than happy to have both of you. So if you want to put yourself on the record, and then we can sort of look forward to. And we have well, we have two new members of the committee, but Senator Lyons obviously is, because she serves on health and welfare, it's not as though she's a newcomer to the world of anything healthcare or human services related. And then Senator Perchlis is the vice chair, and the rest of us are returning. So, but it doesn't matter whether we're new or returning. Refresher and an update is always helpful. So thank you for coming.
Thank you for having us. For the record, my name is Wendy Trofton. I'm the Deputy Director of Healthcare Reform within the Agency of Human Services.
And for the record, I'm Tracy O'Connell. I'm the Financial Director with the Agency of Human Services.
And so if you could talk to us about this topic, or do you have other things you want to talk to us about? It's how broad healthcare reform can be pretty expansive, but
we had planned to come to speak with you today about Section 9817 of the American Rescue Plan, which we often call the Home and Community-Based Services FMAP, or Enhanced Funding.
Right.
So we're going to tell you more about where we are in the process of accessing and spending those funds.
All right, that's good. That's what I thought. But if you wanted to add or if other members want to do like I do, and I've got a question and you're here, then we'll take advantage of the moment. Okay, so let you bring us up to date.
Well, thank you. So this opportunity was available through the American Rescue Plan Act. It provides states with a 10% enhanced match for Medicaid home and community-based services. And those funds can be spent on activities to enhance, expand, or strengthen home and community-based services. So home and community-based services are often defined differently depending on the context. In regards to this program, the Centers for Medicare and Medicaid Services used a very broad definition. Really in the interest of getting more funds to the states in order to make this program a success. So you'll see on the slides, to the right of the slide, it includes the home and community-based services that we were able to claim the 10% enhanced match for. So those are things like home health care, personal care services, case management, school-based services, rehabilitative services, and private duty nursing. It also includes some of the things that we more traditionally think of as HCBS within our Medicaid program. So those are 5 special programs for run by Dale and GMH for people with brain injuries, developmental services, our Choices for Care program, our community rehabilitation and treatment program, and children's mental health. So Vermont was able to claim over $69 million in funds attributable to this increase in FMAP. All of those dollars will be employed as the state share to implement approved activities. The value of those activities is more than that. We estimate it to be $157 million because of our ability to gross up those funds where they are eligible for additional federal financial participation. Time period.
That's a really quick question. We've got school-based services here, and I've been very sensitive to some of the needs we're seeing in child care facilities, including kids up to the age of pre-K. And so how much of those services is covered here within this?
Or as opposed to children's integrated services,
Yeah,
which is
right.
designed for that age group. too.
I'm not sure what services.
I mean, it's an if-any
Yeah.
question.
Mhm.
Oh,
And it
catching you right
is
in
linked in base
Yeah.
CIS.
CIS is
Yeah.
included.
Yeah, so children's integration services was included as part of the FMAP that we were
Thank
able
you,
to draw
Sarah.
down the extra funds.
Okay, so it is
That piece.
included in here.
But I'm not sure if there are any
I
other.
lost too much.
Okay, thank you.
No, but children's integrated services are.
Is here.
And which surprised me because they said that that's capped, the amount of money, and that they can't cap the number of families or children they accept for referral. Is that,
So that is true. So for the.
but you didn't come prepared to talk about.
Well, but I can speak a little bit about that, because so this, for the purposes of drawing in the extra 10%, that was an eligible covered service. So we were able to draw that money in that we will reinvest in the whole system of care for HCBS. But for the particular issue you just described, you will see something in budget adjustment that addresses that need.
Of the higher demand. All right. One other thing, when does this come back to hit us in our pocketbook? In other words, we're allowed to have the advantage of using this money and serving as match, but at some point that goes away, and then the state is going to have to pony up the match for whatever we built for this package of spending or services. When is that going to be? So we can plan our exit plan.
The time periods associated with the spending are
20,
through March 31st, 2025. The federal government recently moved it back a year because states were having trouble spending the funding. So at this point, it's March 31st, 2025, but each activity has a start date and an end date. And we'll talk a little bit in a couple of slides how we really have a strong focus on one-time investments, although there are some areas such as the 3% rate increase.
right, I'm just thinking we are talking about some base increases.
Yeah.
that we,
Yes, correct. For the 3% rate increase, that was built into the 21 budget. Right?
Yes, that.
Yeah. Years are.
Act 154 in 2021.
So we are projecting that we'll be able to cover that rate increase through the end of state fiscal year 24. So through state fiscal year 25 is when we would have to backfill the funds for that 3% rate increase for that particular, because that was a base cost. But for the remaining costs, they were built as one-time appropriations.
to minimize that impact of one-time money being used.
So how much is that?
What are we talking about in scope?
You mean for base that's gonna be made up?
Yes.
Plus.
So how much is the bullet that I've got to wait? a
Well, you
year
plan
from
on
now?
being around longer than the rest of us.
No.
That's next year.
No,
25?
25,
25.
25, a year after that.
Fiscal year
Next
25.
year, 20.
Fiscal year, so we'll
Oh,
be,
fiscal year,
we'll
not
be doing
calendar year.
24 this
This
winter.
year,
So next winter, when I'm sitting,
25.
and you're gonna be sitting here.
Well, that would be nice. I hope,
Yeah,
I hope something,
You better not be passing away before next winter.
all right,
So it's approximately $17 million
17.
Against your total.
gross. So that's gross. So about half of that would be general fund.
And you'll be sitting there too, so
Right there.
17 million.
What's your total budget?
Out of this is 150 for this part of Medicaid.
Is
But if you're talking about all of big Medicaid,
This is pills,
This
but
is-
17's not.
gross,
Oh,
just
they-
remember gross,
Gross.
just gross.
Yeah, so we assumed that we would spend 3 years of it out of this plan.
All right, well, we haven't allowed you to stick to your script.
That's okay.
But you'll learn that we kind of move around as we are thinking of future implications, because we're always very sensitive about one-time money, one-time base buildup, and that's why we're having this conversation. And I guess, yes, we've got to remember, we're talking about fiscal year, not calendar year. So, all right, we'll keep going with your program. Oh, no, we've already gotten through 25.
I'll mention too, just that we've already successfully claimed the funding, so you could claim for 1 year, and that was from April 1, 2021 through 3/31/22. That's the other relevant time period related to this opportunity. Next slide. So all states were required to submit an HCBS spending plan and narrative for approval from the Centers for Medicare and Medicaid Services in order to both draw down the 10% enhanced funding and to spend funding attributed to the increased FMAP. So AHS first submitted our HCBS spending plan in June 2021 and has been providing our required quarterly updates, which are all located on our website. It's also important to note that anything in our spending plan, although it's approved to use the 10% enhanced funding we received, does not constitute approval for additional FFP for the activities within the plan. So we're going to speak a little bit more to that on slide 5, how to make sure we get those dollars to gross up to that higher amount that we've included in the spending plan. So as I mentioned before, we have a strong focus on one-time investments. So as we were thinking through what activities to include in the plan, we really focused on one-time transformational investments to minimize ongoing sustainability concerns that also strengthen the HCBS system. So there's things like supporting the availability of high-performing providers, promoting value-based purchasing within HCBS programs, developing infrastructure and systems to support program improvement and population health management, and furthering care integration across the care continuum, including social determinants of health. We really did this to reflect all of our concerns about ongoing budget pressures and also CMS requirements to include a sustainability plan for any of the activities that we do include within that plan.
Maybe it's later on, but if I were to say, give me an example of what you did to support the availability of high-performing providers, what would it be? And I'm moving ahead too far?
That's fine.
I mean, in other words, I read this and I'm like, well, what does that mean in terms of the delivery system? Or what are we putting in one time that makes you high-performing, and that's a perpetuating benefit, so to speak?
So in terms of availability, we've recently, I should say completed, but we have funding out for the premium pay for workforce recruitment and retention program. We have a slide on that on the end. That
We have a report on that. Came in last summer on premium.
Yes,
pay.
you do. So we, so that use was, I don't know if you want me to go into that full detail. I can go to that slide now if you'd like information on that program, or I'll just note just for this
As an
basis of this
example.
question. That's an example, as well as we have considerable funding set aside for training. So we've been working on a training needs assessment internally. We're planning on developing trainings for providers and also creating a provider grant opportunity for any specialized sorts of trainings that are more provider or agency specific training that may be needed. So those are two of our primary strategies. We've also had bonuses available for eligible independent direct support providers. For some of the larger activities within that bucket. The next step sort of explains how this program works. So the first thing we did was we received the CMS approval of the HCBS spending plan. We received full approval of that in May 2022. We have also successfully claimed the enhanced funding. That's the second step in being able to operate this program. You may have heard us talk last year about our need to make sure that before we spent these funds, that it did not impact our ability to spend Medicaid funds within our 1150 waiver, particularly related to budget neutrality. We have had significant conversations with CMS in this area, and they approved our use of investment expenditures on activities to enhance, expand, and strengthen HCBS. So they are requiring us to use a notification process before implementing those activities, but have been very great partners in ensuring that we can get that additional federal match for most of the activities within the spending plan. And we have received state appropriation of funds for HCBS spending plan activities. So that's within 3 bills noted here. The first one being the rate increase approved in 2021, and then additional appropriations through Act 83 and Act 185. And
We have to make a public, I have to make a public confession. I haven't got a clue what 83 or 185 are. We just go it by.
Oh, yeah.
That's
Yeah.
the budget adjustment in the budget bill.
Oh, good.
I don't know. It's like-
You know what
When they become acts, it's hard.
Yeah, sure.
We'll get paid to go first.
Yeah, right. You're just the BAA or the big bill. All right, well, make a note of that, and it'll go right out of my memory anyway, because I don't need it, as long as I've got somebody who can tell me. Or I do, actually, I keep the budget addendum that we finally pass every year, so, but even that is before it has an act number assigned. So you can see I'm handy.
Yeah. Sometimes it takes a couple weeks before we get
I
the
know.
act number from the Secretary of State.
Well, thank you for that reminder. All right, so now we'll go to the budget. Let's go to the 156, almost 157.
I'll just highlight one more thing on the other slide, is that we are working now on implementing the activities now that we've had all the various approvals, and we've spent 26% of the funding at this point. So the next one is the HCBS spending plan budget. So we have many activities within the spending plan, all sort of in these categories that we've highlighted here today. So the broader categories are really the things that are related to improving services, promoting those high-performing and stable workforce, which I mentioned before. And then we have utilizing systems and data to improve care, promote value-based payment models, and support program oversight. So all of our activities here are itemized in a way for you to see where we've allocated these dollars. As we're implementing them, we're making sure that the funding sort of lines up well with our original estimates. The only item I'll note here that we are unable to get additional federal match on is the capital investments category. Right now, we have $6 million allocated for that, although CMS allows us to spend these dollars on capital investments. They will not match those dollars.
What is a capital targeted for?
So we anticipate rolling out some provider grants this year, which would be giving HCBS providers an opportunity to increase accessibility, promote safety, improve services, promote provider sustainability, and increase energy efficiency in ways that are the bricks and mortar
So if
type.
you had an adult day program that need to expand their kitchen, that might be a possibility for.
Exactly, or add a ramp, or I mean, sort of the bricks and mortar type things that the federal government typically wouldn't allow funding for.
That frankly has been a problem for the programs that are not under rate setting, where capital is recognized, because there's no, within your adult day program or in particular, the cost or improvements to the facility, capital improvements are, they're not, well, that rate has no rationality anyway, as I know how it's developed. But there are certain things that work to a disadvantage. The other part, which is also for community-based providers, like if you're in a nursing home, they have provision for a whole bed. I think it's now 3 days. But if someone's sick and can't go to a program, everything is sort of by hour. So it makes a difference in terms of the predictability of the funding, because those staffing and facility expenses stay and have to be met, even though your reimbursement can fluctuate. You've got some individual who might be out for a week or whatever. So does this address any of that sort of disparate treatment between institutional and community-based?
I'd say that the entire program is focused on only really making these improvements in the home and community-based system. So we can't be using the funding for institutional settings, for example.
No, I know that. Okay. No, I was thinking the reverse in all honesty. For example, the capital, to me, those capital investments are an example of where you're providing some financial recognition of those needs that can't be recognized through other funding means. Bobby, you have a question?
I was wondering, is this figure of 156 million, is that the figure you were talking about earlier, where we would be a shortfall once the federal money stops? Is it that number there? And if it is, that number, 7-8 million against 156 million.
Well, I think
Pretty
what they were
small.
telling us is that a lot of the 157, I'll round up, is for one-time expenditures, and only about 17 million out of this total is ongoing base costs that would in fact require the state to fund the match.
So the question I have, knowing that that's recruitment and retention, why would you have to spend 31.5 million every year on recruitment and retention if you knew you were gonna run short on money anyways? So, I mean, I see some places in here where that could be leveled out without us having to raise a bunch of taxes.
So that program is related to the specific recruitment and retention program that we're running now, that was appropriated in Act 83, the budget adjustment. So that is a one-time investment. The issue with that is a one-time. The challenge with the 156, of course, is we can only spend it until March 31st of 2025.
I wanted to ask about the technology and cross-system data integration effort. It scares me when we talk about spending $20 million more on these things. We've seen disasters throughout state government that just defy logic sometimes. And it's like, I realize that it's all, it's all connected, but when I try to access my health portal, I can do that pretty easily. Southwest Vermont Medical Center. I mean, I have a lab test. They send me the results. I don't know how to read it, to tell you the truth. I have to wait for the doctor to tell me this is good and bad, but at least I got the result. Why is it so difficult? How can you, I'm gonna be specific to the, was it 86 Vermonters died from COVID that we didn't count as died from COVID? I don't know if it made any difference in what we do, but I think general citizens would have been more aware that we were not as well off as we thought we were. That's data that didn't get somehow. And I hate to, pick on it because we do need this ability to cross-reference. We need to do that. I mean, I really am happy I don't have to take 10 pages of reports from my doctor when I leave. So can
Well,
you
maybe
help me? How are we gonna spend this 20 million?
Yeah, maybe that's what we need to hear is what this really means in specifically.
I can provide a few examples in this area. So there's internally, we have funding set aside, and we have funding set aside externally for those HCBS providers. So some of those things internally are case management systems for critical incident reporting systems, sort of DAIL or DMH. These are going to be very helpful in terms of meeting a lot of our obligations under the state's 1115 waiver with Medicaid, where they're requiring a lot of new reporting and assurances that we're meeting programmatic regulations as well as health and safety. So these are going to be ways for us to improve quality and also make sure that we're meeting our federal obligations. Then in terms of the federal, on our partners with our HCBS providers, there has been an HIE incentive program that was for medical providers. We are actually able to expand that to HCBS providers under our 1115 waiver. So $15 million is set aside to help those providers. These are purchase case management systems, electronic health records, or other tools, and connect to the BHI. So they'd be able to exchange appropriate data with the right data.
Would that be like home health agencies? Or?
Yes.
As
So-
a prime example.
Exactly. So we have recently, I think the contractor's on board now to begin getting that program up and running, but that was sort of an exciting part of our 1115 waiver, getting the approval to be able to run that program for that more expansive provider types.
So we're helping those local agencies then with their basic IT systems.
Exactly. And then like ideally, in terms of we have social determinants of health, goals within this too, they'd be able to collect and share data to really make sure that they're providing whole person care. And we're not duplicating and asking people the same questions.
Done with that.
You've done, Jeff, I guess what you're saying is you're using proven technology and you're making it available to the very provider community that's required to, so that you have the data showing that individual's care from in its entirety.
Yes, they'll be able to have their systems, they'll be able to share data, and we'll also be able to receive and populate data at the state as well in ways we haven't. But really need to, given the federal government's oversight within this current waiver period.
And may I ask, we had this whole debate about meaningful use, and I'll get to your questions since we're talking. And one of the things that was not done, and I had suggested it and was rejected, but that I suffered rejection more than once. And that was to select certain systems, medical records that we would support. And Vital didn't want to do that. And, the federal government meaningful use meant there were so many systems. And then they discovered the interoperability and the programming that it took to get to move the data around was really expensive and complicated. And they said, we should have identified these 3 systems that, we will support and we, will authorize for purchase. So I'm assuming that when we're looking at these data systems that are being acquired, I believe our DAs are in the process as well, that there is some oversight to make sure that we're getting data in a way that can be accommodated and exchanged within our existing system without a whole lot of additional work.
Yes, that is part of the work that the contractor will do in terms of program design. I know this is an area that's fairly new, but our partners with the federal government, we're excited about the program too, and they've reached out to us on what are some of the new standards around long-term services and supports that could be available. So we will be looking at that. We will have to create an operational plan and have that operational plan approved by the federal government before implementing the program.
The capital investment, am I correct that you're gonna issue like an RFP to the providers? And then they're gonna say, when do you think that, what's the time frame on that?
We're right now trying to work on standing up a number of provider grant opportunities and trying to come up with the most efficient way of doing the number of programs at once, perhaps through several tracks. So I'd like to say in the first half of this year, we just have to work through the logistics on that piece.
And what's the universe, like how many providers are there that this would be?
So our first initial approval with CMS, they were quite clear that in order to receive these funds, you have to either currently meet HCBS settings criteria, these are federal regulations, or by receiving those funds, you would meet those criteria. So this is kind of a smaller universe of the system of non-facilities, home community-based settings that do meet those criteria. We have had meetings with CMS about could we be a little bit more flexible, for example, a facility or a site that is providing crisis services, so a less than 24-hour service. So we're still trying to figure out need and how flexible the federal government may be. We were surprised that we think they will allow us to partner a little bit broader than their original approval. So I know I didn't give you exact numbers, but it's gone from a fairly small universe to we have some potential to be innovative here.
Like 100 or like a dozen?
I wish I knew how many. I'm sorry.
That's fine.
It could, well, because it depends on, within different regions, you have different players. For example, some designated agencies are also specialized service agencies in there. So you've got the CRT population, you've got the TBI. And so the configuration of agencies, sometimes it's one, and sometimes it's multiple. So, and how big a region they serve. So I bet you're getting at least 50.
Yeah,
on the top of my head.
if you just think of adult days or AAAs or MGAs, you're getting, the number's getting.
Yeah, it doesn't take long.
larger.
Depends on how big the region is that they serve. Sometimes it could be, for example, our public transit serves 4 counties. But in other areas of the state, it might be only 1 or not even all of them. So it's great variability. Other questions before we don't keep to the script. We'll keep going then.
I'm happy to, I didn't want to walk through this whole piece, so I'm going to assume that if you had any questions related to the budget line items, I can answer those.
Well, we had obviously at the agency, because of COVID, we had put a lot of money into the healthcare workforce in a variety of ways. And so the recruitment and retention was a big piece of that because of just that workforce. But the other part that we've been trying to do here is recognize that it's not just recruitment. If you've got an inadequate supply, then everybody's competing for an inadequate number of nurses or dental hygienists or whatever. And so in the budget, we have tried to think about how do we increase capacity of these educational programs so we can start generating the supply that we need. And nurses are an example, and the study was showing, well, Rich knows the numbers right off the top of his head in terms of with retirees. And the other thing is we talk about demographics, but the reality is the baby boomers are retiring and the next generation is much smaller. I mean, we just did not have the same childbearing patterns as the prior generation. So we have a much smaller cohort. And you don't have to be a great mathematician to know that you're going to have fewer people. And so the question is, how do we make sure that any Vermonter who's interested and got the capacity, and we found out that there are many more qualified applicants to go into these programs than the programs can accommodate. So we try to look at it in two ways. How do we keep what we've got? How do we recruit the best we can? But how do we begin to address the basic underlying problem, and that is the numbers, the supply. And and this is totally unrelated to your presentation, but the University of Rhode Island Medical College sends out this quarterly news, and I do read it. And I found something very, very interesting. There was a man, Abraham Flexner, who at the beginning of the 1900s went around and advised in colleges and universities around how to economize and save money. And he recommended that many universities shut down their medical colleges. And about half took his advice. UVM rejected it and kept their medical school. Dartmouth accepted it in a modified way and had a 2-year pre-med, and then you had to transfer to, my cousin went to Harvard after that because it was only, so it was not, I think 1974, it was 60 years that they went without an MD program. And Bowdoin had a program and they shut it down. And they wanted basically 2 medical schools in New England, Harvard and Yale. And about half the programs that were shut down educated Black physicians. And here we are a century later, and we're yielding really the results of what that meant in terms of the adequacy and the fact that we have such health disparities when you think about it. So just sort of put a new spin on the decisions we make today. What does it really mean in terms of what will we be confronting or what will be created 5 decades out. But anyway, if you haven't read the article, I found it quite, obviously I found it rather interesting because my life is very
Sounds like
boring.
you actually read it.
What?
I said, it sounds like you actually read it.
I did, obviously. But I was thinking, gee, when we talk about health disparities and, the populations that are underserved from a health perspective, the shortage of physicians and primary care physicians. And the other thing is we shut down all our nursing programs that used to be operated by hospitals. Hospitals created their own workforce, and St. Johnsbury had an excellent RN program, and all of a sudden they shut down, and we relied on academic institutions. And so we constrain the supply, the very systems that help generate and train medical professionals. So anyway, that's my history lesson on why we're having such a problem here. But it's kind of interesting in case you haven't, I found it interesting. So you don't need to read it because I summarized what it said.
When are we gonna have the?
Well, I thought it was really fascinating. I thought it was fascinating to see where we are today and the very issues that we've got. And so, anyway.
Pretty fast. Didn't take that many years to get turned around, twisted on the
We
side.
have people that are in nursing homes that can't go to nursing, in hospitals that can't go to nursing homes.
Because we don't have
staff
the,
shortage.
yeah.
We have people in hospitals who should be in a mental health facility but can't go there because there's a shortage. We are misutilizing many of our services.
Either that or everything we're solving one problem, we're actually creating much larger one.
Right.
It may take a little while for it to.
I guess we shouldn't have sold the week school.
We never called it weak school. We called it, we could have called it the gems. Every Vermont kid got threatened with that.
I know.
If you don't shape up, you're gonna end up in gems.
And Harrison thought it was a
Harrison Green,
prep school.
he did, they had a band that was amazing. We're talking about the juvenile facility in Virgins. So everybody, you were sent to, every institution took on the name of the location. You were sent to Waterbury, or you were gonna go to week school, or you got sent down the river to Windsor.
Or Brandon.
Or Brandon.
I had a kid in my class that got sent to Virginia's.
And it wasn't you, Bobby.
Oh, I was an angel.
That's because you got threatened. We all got threatened.
They're gonna send me to Windsor.
Oh, it's our five man said, they didn't put me in the castle. I got sent to the farm. So,
We went to Westboro in my new area.
oh, did you?
Yes.
But actually, I remember going, I was not a basketball player, but I was part of the team that helped pick up the towels. And we played at Westboro against the school lads. It was quite, you could look up and they were all allowed upstairs and the guards had, billy clubs and stuff to keep them under control.
But you went to a prep school.
That was after I went to prison.
Yeah, what?
He was reformed.
I guess, apparently, huh?
No,
So we've kind of bounced around and you've got some old, but you have to realize there's a lot of institutional knowledge sitting around this table.
Depends on the case.
some of it we've forgotten, and I have to add, I made a quote today, it appeared in Vermont Digger, that I did not intend. Well, I can't remember why we didn't take up your bill, and I actually said it. It was so stupid. She said, well, why didn't you take up the bill last year? I said, I don't remember it.
Why'd you say when I'm old?
We can read what you actually said.
You ran out of time.
Well, I wish I had said I ran out of time, or
I'm surprised you
I
did.
should have blamed Senator Baruch. He never asked me to take it up. I could have said something that stupid, but when I read it, I can't remember.
Well,
There was a good
very
reason.
interesting probably for you as well, right? But believe it or not, we do manage to get it all together. In spite of our somewhat,
We don't remember why we did it.
because we can't remember.
I can't remember.
Oh.
I'm gonna vote for it.
So everything is going well, and it's kind of interesting, sort of the interconnection with the 1115 waiver. And I think, certainly we see what happens with some of these systems in terms, because the hospitals are saying, we cannot refuse. And so we're ending up with the nursing home patients that they can't take because they can't meet the staffing standards. We're dealing with the person in a mental health crisis because there aren't enough beds, or the state hospital can say, we have an empty bed, but that patient would not be compatible. And so they can reject a patient, and hospitals on the local level are saying, we have expectations and responsibilities that are given to us that other parts of the system can walk away from. And it makes it very difficult situation for hospitals at this time. So and so where are we seeing more? And we had language for those who were not on the committee last year around looking at reimbursement under PNMI facilities and nursing homes, because the base year is 2019, which is so out of kilter in terms of what is the cost of operating the facility at this point. And I assume we'll be seeing something in the budget adjustment on that.
Representative Hooper forgot to put it on the agenda of the last joint fiscal committee meeting. The report was not what we were looking for.
No, but we said we would get an update
We
here.
got an update here, so.
Yeah, so that we will, because that's what I told her, that I would plan as part of our updates. And I think maybe we will be getting that update as part of the budget adjustment to some extent, because I think some of those rate increases are going to be reflected in the budget adjustment. You can tell me, because you've already revealed it at the house. You're being very, very quiet.
On the nursing home side, is that what you're referring to? Yes.
Well, I can look at my sheet, it's right here, but I haven't had a chance to, it's on here, isn't it? Stephanie, it's on here?
For the nursing home piece?
Yes.
Yeah.
How much?
The choices for care budget adjustment in total is a $21 million increase. Part of that is for the vet's home, the cost settlement there, but.
And what are we doing with the PNMI facilities? I'll ask, and Senator Sears is always, those are the group homes, oftentimes for treatment for kids in the custody of the state.
There's an inflationary adjustment to the rates and budget adjustment in DCF and DMH.
We'll take a look at that, because that was the concern, was they were having to pay for per diems as well, and what that meant to their bottom line. So
Well,
we'll
I
get
also
that.
had to increase salaries just to get workers.
Yeah, because those are difficult work environments, certainly.
Yeah, I just saw a sign on the,
Maybe you could go back to work.
I could, at $20 an hour, they're starting at.
Well, that's almost as much as you earn here.
Yeah.
Not quite.
Better than corrections.
Yeah.
I feel like 19's up, right?
Are they for their plus the benefit package? right?
Well, the state benefit is probably
If you
better.
add up everything you
Yeah.
do, I did that.
Yeah.
It's just-
Anything else that we didn't ask that we should have?
If you'd like, we have one more slide on
Oh,
the
okay.
premium
All
pay
right.
for workforce recruitment and retention program, give you an
You
update on
might
that.
as well get the whole presentation.
So here, this is the Budget Adjustment Act allocated 60 million for certain healthcare and social service employer supervised premium pay for workforce recruitment and retention. So we had our first round, 25 million of those funds were HCBS FMAP funds from this opportunity. It also included some state fiscal recovery funds and general funds. Through that program, grant awardees received $2,000 per full-time equivalent employee that they could then distribute to eligible employees. So we wanted to just note that 140 first-round applicants qualified and were awarded $33.1 million.
So was the take-up rate what you expected?
It was quite high, yes. We were, we did a lot of outreach. It was,
So I think there was some concern about that in terms of, you know,
We've had over 80% take-up rate. Some of the employer types, we had 100%. But really it was easier in some ways because these were known providers, which we had provider lists, unlike some of the hazard pay programs, which we couldn't reach out and contact everyone because they were all known entities. But so we've spent over 23 million in the HCBS FMAP funds on those, on this program. Nearly half of the awards were taken as a quarterly disbursement option, so they can spend those funds through June 2023. we also provided an option to allow them to take the lump sum and spend it over 90 days, which helped with cash flow issues for those who really wanted to get the dollars out immediately. So we also allowed that. We're looking to really evaluate this program through data collected this month. That date is due January 17th, and then we will be collecting data again in July, so mid-program.
And I did have a requirement of what, 3 months commitment? Of
So
course,
they
if you're
have,
doing it quarterly, then you have to, that almost ensures that you're,
They have
as opposed to taking
agree
it
to
all.
Stay on for those
Uh-huh.
3 months.
exactly, the employers had them sign a service commitment before dispersing funds. We are getting ready to start a round 2 of applications based on the approval we received from JFC on new eligible employer types. So we'll be providing opportunities for anyone who missed round 1, as well as primary care practices, dental offices or facilities, therapeutic community residences. Some of them are owned by DAs and SSAs, so some received funding in the first one. So this is parity for those who did not receive it, and high-tech independent home nursing providers. Similarly, those who are employed by home agencies received funding. So that's where we are in terms of that program, which is one of our large.
Andy, you have a question?
So is that second round the full 31 million that we budgeted here? Or that's, part of that was already spent in that first round?
So that budget adds a few things together. That is, the premium paid 25 million, has bonuses for independent independent direct support providers, and may have a couple other areas in there, but it's the HCBSF map component. We spent all but 1.5 million here.
Well, other questions? We have,
So the 11 million, that's what you had left from that first round, you're gonna do for the second.
For premium pay?
Yeah.
Yes, so we have remaining, we've awarded 33.1 million out of the full 60 million. So we have less than $30 million left in order to go towards a round 2.
which has these new group of providers. It's the way it was set up. Have this group apply first and then fund the next group of identified, which is what joint fiscal approved at the last meeting, is this expanded group.
That has made a difference on that. Being able to sign the employee up for like 3 months. We had a good, like at BNA and Newport, we had quite a few. No argument at all. We're glad to stay for another 3 months.
That's great.
Yeah. So they signed up and got their little bonus and it's worked well.
We've heard good anecdotes, and we're excited to see the data as it comes in.
One thing that has come up, actually, Senator Westman and I were talking about that, and that's been the impact of enrollment in Medicare Advantage plans on these community-based providers, particularly nursing. And obviously it ties in because there's a proposal around retired state employees to move into an Advantage plan, but individual plans seem to be where there's a lot of problems, and providers are very upset with them because they either deny claims or they set eligibility criteria, or they constrict the network,
And the
or
rates
they
are lower.
put in more prior authorization requirements. So what has happened in your area may be statewide, and maybe you've heard of it, but it has to do with the payments that VNAs and visiting and home health programs are getting under the Medicare program. So it makes you wonder if maybe the efforts we're doing on this side to bolster, in fact, are being undermined by that migration into these Advantage plans.
I home health agency is expecting a deficit this year.
Those are
First time in
managed
5 years. And because of the plans.
should never
And they can change, and they're totally unpredictable.
So that's kind of an external force at work, and there's got to be a lot of money in it for the plans. You have to watch TV just about every other ad is an insurance company, and call this number, and licensed agents are there to help you. And you can get free gym, and you can get your teeth fixed, and you can get a hearing aid, and you can get, it's like and I can see why people would say, gee, and I don't pay a premium. So,
It's all free.
it's
That's the way it sounds.
it's obviously very enticing if you're looking at those ads to say, why wouldn't I want to make that switch into a privatized plan compared to the traditional one? But have you heard this before now, in terms of, maybe the folks in Dale have heard it more about those Medicare changes in coverage and enrollment change, what's happening on that side is having.
I've certainly heard sort of nationally that the increase in penetration of the MA plans and concerns in that area. I'm not as familiar as the comments you made around home health rates in Vermont as a result of that.
Instead of having them check it, we should have the AG check it.
Well, we wrote a bill last year in health and welfare where we tried to set some criteria for the Advantage plan so that they wouldn't be so flexible and changeable from the time of sign up, and also maintaining the in-network access. And it was changed. It got changed. The bill got changed. And it ended up, I think, I'm trying to remember exactly how it ended up. I'm right. But it was more about communication and letting people know that this is what an Advantage plan is as compared with a Medicare supplemental. And it is huge. It is absolutely huge. And it does detract from what you can expect. When you sign up for a supplemental, you know exactly what to expect. It's going to hold for a whole year. When you sign up for the Advantage plan, it could change tomorrow. Probably exaggerating a little bit here, but honestly, I think it's something that the finance and health and welfare coach should do.
Well, if there's all kinds of savings
Well, there are savings
and where they.
because you can cut services.
But
Pay for the drugs that people need for their transplant.
Well, but I think across the board, the real question is, where are those savings being created?
Yes, exactly.
And I think it's not only what you're being denied for service, but there might be a number of different places those savings are being created that were non-intentional.
Well, let me just add to that those of us who are paying for home health services out of pocket are paying a higher price. As you know, I do have long-term care insurance, but it's not unlimited.
We have that in nursing home too, private pay versus Medicaid.
And so I'm paying more for my wife's care than I would otherwise to make up for the Medicaid. But now I'm making up for the Medicare Advantage plans as well. And that bothers me. Because eventually we'll all be on Medicaid if we live long enough.
Well, on that cheery note, other comments? It's just something I think we need to start paying attention, because sort of like shutting down the medical colleges is going to catch up with us in some form.
Yeah.
And could actually be detrimental to the stability of our community-based service agencies. Well, it's nice of you to come in.
Yes, thanks for
Chat.
having us. Appreciate it.
And we'll be hearing more on the budget. Sure.
Thank you.
So we actually have a break scheduled. Oh, nice.
It's gonna be a budget.
Wow, it sounds like you were late getting here.
If we remember to take it out.
You watched.
And then we do the Ed Fund next, an update on the Ed Fund.
Good.
Good. And then tomorrow, we're doing the broadband in terms of, the millions that we put in, and also we're applying for, I believe there's the match that's in the budget adjustment, so to get the grant, the state
You know,
match
it's
is there.
all in the budget adjustment.
What?
You know everything in the budget adjustment.
No, I don't know everything. I know what Stephanie's told me, it's big.
99%.
Would you like that?
Big.
Should you want, Adam is in on Thursday, but we can get you the documents that, or the summary documents.
Yeah, just coming in Thursday, would be good to see it.
All right, we can do that.
So we're back in.
Dentist appointment
That's right.
tomorrow, so I missed the broadband thing.